Thank you very much for joining us tonight at our latest Medicine for Members event. My name is Jane Gisbert, and I'm joining you tonight in my capacity as a Royal Free London elected public governor. The other hat that I wear is as Director of Communications for the National Institute for Health and Care Excellence, NICE. NICE is an arm's-length body of government that produces guidance for the NHS and social care on a wide range of topics, including all types of cancer. Those of you who are new to the Medicine for Members event, they are organised and chaired by the Council of Governors. These events focus on topics that we know are important to you, our members. They give you the opportunity to hear more about the Royal Free London services. Our topic tonight is breast cancer at the Royal Free London, early diagnosis, research and support. The Royal Free London is one of the largest cancer services in the NHS, receiving almost 50,000 referrals every year. The most urgent suspected referrals we receive are for bowel, skin, gynecological and breast cancers. Cancer care forms a key pillar of the Trust strategic plan and of the Royal Free Charity clinical strategy for the Trust and the strategic plan for the Royal Free Charity. Thanks to the charity and their generous donors, we've been able to improve the support we offer our cancer patients, including providing a scar tissue massage therapy for those who have gone through surgery. They are the only NHS charity in the UK that provides this service. We've also been able to ensure our clinicians have access to lasted equipment and technology, thanks to the Royal Free Charity. This includes funding our new state-of-the-art £8 million positron emission tomography scanner at the Royal Free Hospital, which allows patients to receive their diagnosis and start treatment sooner. Breast cancer is the most common cancer in the UK, with over 55,000 cases diagnosed each year. 1 in 7 women will develop the disease in their lifetime, and 1 man is diagnosed every day. Tonight's event will focus on the importance of early diagnosis, including how often and how to check your breast for the common signs of breast cancer, the groundbreaking research taking place to help us better understand the disease, and the vital support that is available to our patients and their loved ones. Our expert panel of speakers will also share advice on how you can reduce the risks of breast cancer, and they will debunk some of the common myths around what causes the disease. This evening, you'll hear from Claire Mabena, lead breast cancer care nurse for the London Breast Screening Service and the Central and East London Breast Screening Service. Judy King, consultant medical oncologist and clinical service lead for oncology and palliative care, and Kathy McDade, lead nurse for metastatic breast cancer. They will be joined for the Q&A by Kim Stoddard, Chief Operations Manager for the North London Breast Screening and the Central and East London Breast Screening Service, and Stephanie Scott, Superintendent Radiologist. Before I hand over to the presenters, before I hand over to our presenters, there are a few housekeeping points I'd like to make you aware of. To ensure the event runs smoothly, you are set up to view only. This means your cameras have been disabled and you are put on mute. If anyone experiences connection or visual problems, a recording of the meeting will be available in the coming days. A link to the recording will be sent out to all members after the event. After the presenters, there'll be a Q&A session. We've had several questions submitted in advance, but please ask any questions you may have through the Q&A chat function, which is on the right-hand side of your screen. We'll do our best to answer all the questions asked. The speakers will not be able to answer any questions specific to you or anyone else's care or treatment. If your question is not answered, please send it to the membership inbox, and we'll let you know how to do that later in the session. If you'd like to contact the Council of Governors with any queries, concerns, or comments, please do so via the Governor inbox, which is on the screen now. I hope you enjoy the event, and I'll now hand over to our first speaker, Claire Mabena. Thank you.
Hi, good evening, everyone, and thank you for having me. My name is Claire Mabena, and I'm the lead CNS for the breast screening services. Next slide, please. So here in the UK, we diagnose over 55,000 cases of breast cancer here in the UK. These were the statistics from 2016 to 2018. In relation to deaths from breast cancer, unfortunately, there are about 11,500 annually in the UK. This, however, is an improvement. Our survival rate for 10 years is sitting around about 76%, and this continues to improve year on year, which is really positive news. With regard to preventable cases, statistically, we can prevent about 23% of these breast cancers from developing by simple changes to our lifestyle. Next slide, please. So over 1 in 7 women will be diagnosed with breast cancer here in the UK in their lifetime. It is the most common cancer. Breast cancer is the most common cancer here in the UK, and it's the most common cancer in women over the age of 50. Like I said before, with 23% being preventable. And it's never too late to make changes. Even the smallest changes can have quite a significant improvement. Next slide, please. So although the links between breast cancer and diet are not definitive, there are benefits for women who maintain a healthy weight. So a healthy, balanced diet, a healthy dietary lifestyle is really important. Exercise regularly. Now, this can be something simple as getting off the bus, the stop before, and just making simple introductions into your daily life. It is taking the stairs instead of taking the lift. And again, you know, with the train, you could get off at the stop before. So it's small little changes. I'm not talking about running a marathon. It's just little changes you can introduce day by day. Having low intake of saturated fats within your diet as well, and reducing your alcohol consumption. So this could be reducing it down just by 1 glass of wine over the weekend. If you're somebody who drinks on a regular basis, again, reducing it by 1 or 2 glasses can have a significant improvement. Next slide, please. Breast awareness is getting to know what feels and looks normal for you, so that you notice if anything changes. People of any age or any gender can get breast cancer, so it's important for everyone to be breast aware or chest aware. Everybody's normal is different, so it's important that you are doing your breast checks yourself at home. Only you know what your body feels like. So if you're not doing your breast checks, you're not going to know what's normal for you. So detecting changes as they occur is going to be more challenging. Next slide, please. So touch, look, check, TLC. It's a really simple way of trying to remember how to check your breast. So it's about knowing what's normal for you. Know what changes to look and feel for. Look and feel for those changes. Now, we say generally at least once a month, if you can do your breast self-examination at home is really important. If you do find anything, please go and see your GP without delay so they can assess you and refer you to the appropriate clinic if necessary. And if you are over the age of 50 and you get your invite for your breast screening, please do attend. Next slide, please. So these are more of the common signs of breast cancer when you're doing your breast examination at home yourself. So there isn't any right or wrong way to do it, but these are the signs and symptoms that you're looking for. So a new lump or a new swelling in the breast, or a change in the skin, such as a puckering or a dimpling within the skin itself. So this is something you will generally observe in the mirror. A change to the color of the breast. So if the breast becomes red or inflamed, and this is a new symptom for you, this needs to be investigated. Any changes in your nipples, such as any kind of inversion, pulling to one side, or puckering. Any rash or crusting around the nipple areola, or any liquid, which is new for you, discharging from your nipple, or you might find spontaneous staining in your bra. Or changes to the shape and size of your breast, which is new and is different for you. Next slide, please. So here are some of the myths that you may have heard of, you may not, and there may be others that you're aware of. But shaving, deodorants, and antiperspirants, none of these are responsible for breast cancer. Obviously, here in the UK, all products like this we use go through rigorous testing. They wouldn't be for sale on our shelves if there was any risk in relation to this. An underwired bra. Wearing an underwired bra will not put you at increased risk of developing a breast cancer. If that's what's comfortable for you, and many of us will need the support of an underwired bra, there is absolutely no risk at all in that. Bumping or bruising your breast is another one. Again, that is just a myth. That doesn't at all increase your risk or cause breast cancer. Hair dye is another one we often hear about, and a mobile phone in your bra. I mean, who would want to keep a mobile phone in their bra? I'm not quite sure. And if you can fit your mobile in your bra, you probably do need to go and have yourself measured, because you're probably not wearing the right size bra. You'll not get breast cancer without a family history. The reality is only 5% of the breast cancers we diagnose here in the UK have a family history. 95% do not. So the majority of people we do diagnose do not have any other significant family history. Chest binding and breast implants are the other two. Again, they do not increase your risk of developing breast cancer, or they do not cause breast cancer. Next slide, please. Again, this is another that we use in relation to just talking through about breast awareness. And this is some different ones from the previous slide, which is why I'm including it. So if there is an area of thickening within the breast when you're doing your breast checks itself, any dimpling, we did mention before about nipple crusting and inflammation or new fluid, any skin sores within the breast itself that are new or develop and aren't healing, any new lumps or bumps. If you have any new predominant, what looks like a growing vein within the breast itself, again, sunken nipple, new shape and size, orange peel effect on the skin, or a hard lump. And again, any of these symptoms that you find, the advice is please go and see your GP. So anything that's new, anything that's different for you month on month, please go and see your GP straight away. Next slide, please. So these are the two routes of referral. The first is if you do find a new lump or a change within your breast itself, go and see the GP. GP will then refer you into your local specialist breast clinic, and they will give you an appointment within 2 weeks. And that's the symptomatic pathway. The screening pathway is where women between the ages of 50 and 71 with no symptoms will get an automatic invite in the post once they reach eligible screening age, and they will be invited every 3 years during that time for their annual screening mammograms. Next slide, please. So all women registered with a GP between the ages of 50 and 71 will be invited for their breast screening every 3 years. The first invite will arrive before your 53rd birthday, and women over the age of 71 can self-refer every 3 years till the end of life. Next slide, please. What is breast screening? Well, breast screening involves taking a type of X-ray, which is called a mammogram, of your breasts. The mammograms will be examined by 2 trained healthcare professionals who will look for any unusual changes on the mammograms. Breast screening helps to find changes in your breast when they're far too small to be seen or to feel. This means we can pick breast cancers up at a very early stage where they are more easily treatable. Next slide, please. This just to give you an example. So looking at the screen, so your regular mammograms, these tiny little areas, they can be detected within the screening mammogram. Obviously, if you're examining yourself, you wouldn't be able to detect things that small by doing your self-examination. The second or the third and the fourth spheres that you can see here are more likely what you would pick up doing your self-examination. So just to illustrate how breast screening to detect things at such an early stage, which is why it's so important that ladies who are of eligible screening age and are invited do attend, so we can pick things up long before they can be felt. Next slide, please. So 2 specially trained healthcare professionals will examine your mammograms. You will be sent the results in the post around 2 weeks afterwards. Most people will receive a normal result. So for every 100 women that we screen, 96 will receive a normal result. 4 will be recalled for further assessment, where 1 will be diagnosed with an early breast cancer. But even with a normal result, you still need to be breast aware. We only screen every 3 years, so doing your monthly breast checks at home is really, really important. Next slide, please. So, like I said, sometimes you'll be asked to come back to attend the assessment clinic for further tests, such as a mammogram or an ultrasound exam. This is because something has been seen in your mammogram that is new or unusual. It does not mean that you have cancer. And most women who attend assessment can be reassured and discharged on that same day. Next slide, please. Like I said before, for every 100 women we screen, we call 96 are reassured, and 4 ladies are recalled back for further assessment, 3 of which are reassured, or 1 of which will go on to be diagnosed with a breast cancer. Next slide, please. We also support the high-risk screening program. So that's for people with an increased risk of breast cancer. So such as those with a significant family history, or those who have higher risk because of their genetic mutation status. This can often involve more frequent screening before the age of 50, which often involves MRI scans. If you think you fit within this group, seeing your GP for referral into your family history clinic or genetics is the action you should take. Next slide, please. So we do a lot of health promotion within the role free, and these some of our plans for 24-25 with our health promotion team. So we're working at the moment with people with learning disabilities across all of our boroughs. So what we're doing is those who have not attended for screening, we're engaging with them to try and support them by making reasonable adjustments for them to attend their breast screening appointments. We're also working with people who've got physical disabilities to make sure, again, we make the reasonable adjustments necessary to support them attending. So we're directly working with these people who have not attended. We're also trying to encourage those that are experiencing homelessness to attend for their screening. So again, this involves reasonable adjustments, training for staff and the stakeholders who are working with those experiencing homelessness in the community to support them to attend for their breast screening, and supporting with breast awareness sessions and breast screening awareness sessions as well. We've also just started looking at how we can improve access for those with severe mental illness. And again, it's the adjustments that we can make and the support we can provide in getting them to attend. We are also working very closely with our Black, Asian and ethnic minority communities, focusing with the Somali, Turkish, Greek, South Asian and Romanian, and that's going out into the communities, talking through about the barriers that exist, trying to break those down to encourage these groups to attend our screening, again, to promote access to our national screening service to these groups. The general health promotion that we're involved with is youth engagement, so going into the schools and supporting from secondary school onwards. And again, it's those who haven't attended, trying to engage with them to support them to attend their appointments and to make whatever reasonable adjustments we can in relation to getting them to attend. We're also our Jewish population screening. So this has been screening that was introduced beginning of this year. So what we're doing is we're promoting and increasing the awareness and knowledge of this Jewish population screening that is available for everyone who has had a first-degree Jewish relative, because we know that the population risk in relation to them having one of the BRCA mutations is quite high. So this is a new population screening program which has been rolled out, which we're supporting to spread the word in relation to. And also, obviously, GP primary care engagement is really important for us to spread the awareness of the national breast screening program and to continue to try and improve on uptake across the ICBs with regular engagement with focused GP groups where the uptake is really low. Next slide, please. So looking at research, so we're really looking here at the role free. So in screening, we're supporting many different research programs. So Prospects is one of our research trials. So currently, our Prospects trial, our uptake was below par is what I would say, but we've had some real good investment from our research team on the ground. And we're currently recruiting 200 plus participants per month. We want to improve this. We've had a individual who's dedicated to recruiting for the Prospects trial on site, and that really has helped to increase our recruitment and participation from April of this year. So this is a new way of looking at screening, and it will be interesting to see how the results come through. We also have recruited to the BRAID trial this year, so we've got 80 participants. This study stopped recruiting in March. So the final scans will be completed this month in June, with the follow on appointments in July. And the final number of participants for this study will be 701. Next slide, please. So also just to mention the small trial. So the small trial is where we remove tumours which are less than 15 millimeters, not using standard surgical technique, but using a vacuum biopsy technique where patients are randomized. So this year we've recruited 3 participants. This study will be ongoing until 2029, and it stops recruiting in 2024. So currently we have 15 participants within the trial itself. Also, the LORIS trial, we've stopped recruiting and we're currently in follow-up for that. And you can see the numbers in the bottom of my screen there for LORIS, small, BRAID and Prospects in relation to their recruitment. Next slide, please. So research, we're hoping to have 2 more members of the team who will replace ones left in 2023, and we're aiming to boost numbers by 200 and 250 for the Prospects trial. And the small trial, we just have under a year left of recruitment, and we're hoping to add at least 6 more participants. And for the LORIS, we'll continue to make sure all participants receive their annual follow-up. Next slide, please. I'm handing over to Judy now. Over to you, Judy.
Thank you very much to the organisers for inviting us to speak this evening. My name is Judy King. I'm one of the consultant medical oncologists specialising in breast cancer based at the Royal Free Hospital, but Kathy and I also work over at Barnet Hospital and we deliver oncology at Chase Farm as well. So I'm also clinical lead for oncology and palliative care across the trust. But tonight I'm going to give a little bit of an insight into research at the Royal Free, focusing on the breast cancer pathway. Right, so what we'll do is we'll look at the normal breast cancer pathway and then see where we're looking at that pathway and how we can improve our patient selection for clinical trials. And then the other thing that we're looking at is how we can look more widely at research across the whole sector, including interacting with the pairs building. So as we've heard, early breast cancer is either diagnosed via the screening service or via people who feel a breast lump and go to their GP. And generally speaking, we split our patients into either low or high risk. The smaller cancers, the lower risk cancers, they would tend to have surgery and then probably radiotherapy. And for the vast majority of people, they have what we call a hormone responsive cancer and they would have endocrine therapy. That would be standard of care. However, there are some patients who have higher risk cancers where we would give the chemotherapy first and after that do the surgery and then any radiotherapy or endocrine therapy that might be relevant. So the thing is that when we designed clinical trials in the past, we put all of the early breast cancer patients all together. So they would all go into the same adjuvant study. And that didn't really feel like it was doing people justice. It was a bit one size fits all. So that's not what we do anymore. So let me just talk a bit about how things have changed. So for lower risk patients, we try to de-escalate treatment, i.e. give them less treatment so that we can spare them some of those toxic side effects. And the way that we do that is to look a bit more carefully at the cancer biology. So, for example, we have recently finished recruiting to a radiotherapy study called Prime Time. And what that did was we already knew that they were low risk because they had smaller cancers, but then we looked under the microscope to look at something called Ki67, which is a marker of how quickly these cells proliferate or how fast they divide. And if they were dividing slowly, then half the patients have been randomized to omit, so to not have the radiotherapy at all. We also have another study ongoing where we're doing the same thing, but trying to see whether or not we can omit chemotherapy. So in this study, which is called Optima, and it's running at all the sites across the trust, patients are randomized to a Prosigna test, and this is a bit like the Ki67, but it's very much more complicated. It's 50 genes. You don't need to know how it works. The point is, it's a clever test and it tells you something about someone's prognosis. And so only in those low risk, good prognosis patients are they being randomized to potentially omit chemotherapy, and therefore, of course, all of the side effects of chemotherapy. So de-escalating treatment according to biology. However, not everybody has good biology, unfortunately, and so there are other things that we're doing to escalate our treatments, so to step it up if the biology doesn't look so good. So we talked about Ki67, how it's a marker of proliferation in cells dividing. So in the Poetic A study, which we're also running across all 3 sites, if that proliferation marker is high, we know that those patients don't do so well. So that the Poetic A study randomizes those patients to add in a new drug called abemaciclib, which we already use in other settings. We've also got the Track ER study, which again will randomize patients to add one of these newer drugs, but only if we can detect circulating tumor DNA in the blood. And the premise there is that cancers do shed DNA into a patient's blood, and if we can measure that at really microscopic levels, that's a high risk feature. And so we can identify those patients a bit better. There's another way that we escalate treatment in standard treatment for higher risk. There's different types of breast cancer, and there's one called HER2 positive. There's one called triple positive or HER2 positive and triple negative, sorry. And these are the more higher risk cancers that tend to be more chemosensitive and also have a higher risk of the cancer coming back. So even in standard practice, we have now changed. So we give the chemotherapy first, then do the surgery, and then decide what we do next. And the reason for that is that we can therefore use the specific response of each individual patient to decide what their prognosis is and what should we do. So, for example, if you look at this graph, what this is telling you is how likely a patient is to have their cancer not come back. So in the yellow line and the blue line at the top, you can see that the curve is very high. So that for those patients, the survival is very good. And those are the patients who we've given them chemo and it's shrunk away almost completely or very nearly all gone. So we know how much they shrink is a very important prognostic marker. However, if you look at the grey line or even at the red line below, you can see that survival is dropping lower and lower. And so what that's telling you is the amount of cancer that's left behind tells us something about how likely it is that that cancer is going to come back. Now, in standard clinical practice, we do already escalate the subsequent treatment if there's more cancer left behind, but we're also using this platform to identify those high-risk patients so that we can offer them new drugs and clinical trial opportunities. So, for example, the top 2 lines, the yellow and the blue, we know they're going to do very well anyway, so we wouldn't want to add anything new. But for this other group, the grey line and the red line who do badly, we were running what's called the A-BRAVE trial. And this is a study where patients who have cancer that's left behind, that the chemotherapy did not get rid of, they were randomized, half of them received a new drug called avelumab, which is a type of immunotherapy. And at the Royal Free, we had the very first patient in the country entered into this clinical trial. And a couple of weeks ago, I was at the American Society conference in Chicago, and they presented the results of this study, which showed that the group that in this study who got the new drug had a better overall survival than the group that did not. And so that's really what our trial portfolio is all about, sort of offering our patients those opportunities to these new drugs well before they become available in standard clinical practice. HER2-positive breast cancer is another type of breast cancer that's generally quite aggressive and that we would give chemotherapy. And again, the same is true. So the amount that the cancer shrinks in response to the chemo before surgery tells us a great deal about how well that patient is going to do. So again, at the top, the blue and the yellow lines, these are patients who the cancer has almost completely shrunk away with the chemo, and you can see they do very well. But again, the grey and the red lines are the cancers that have not shrunk in response to the chemo, and they're more likely that those cancers will come back. And for those cancers, we're also running a study called Astefania, which is the addition again of an immunotherapy drug called atezolizumab. We have lots of fancy drug names, but all you really need to know is that for those high-risk patients, we're using this biology, we're using the individual response to that patient's chemo to identify the patients who we think are at high risk, and then offering the opportunity to enter into a research clinical study so that they may have the opportunity to get access to these new drugs. And that study is currently ongoing. We expect results in the next year or two. The other thing that we can do, so we've talked about escalating for bad biology when we look at the response to chemotherapy, but the other thing that we can do is to de-escalate treatment. So in this group at the top, we can see already that they do very well. The question is, can we actually de-escalate what we would normally be doing? So normally we would do radiotherapy, but we'd also usually give a further year of treatment. And in the HER2 radical study that we're in the process of opening at the moment, we're going to be offering this group of patients the opportunity to enter into a study where they get less treatment. So escalating for high-risk disease and de-escalating for those people that have responded very well. So in summary, our aim is, as it always has been, to have a clinical trial available for every patient that walks through the door. But what has really changed in recent years is a better definition of high risk versus low risk biology, so that we can offer patients either an escalation or a de-escalation trial that's more appropriate to the individual patient. What I haven't talked about today is the huge, and I do mean huge, expansion in the number of drugs, drug combinations, immunotherapy, antibody drug conjugates. So that is all also ongoing. The last thing that I just wanted to say is that anyone who's been to the Royal Free kind of failed to notice that we've had the Pears building go up next door. So we've got a very big clinical research facility that recently our professor and director, Tim Mayer, won a £5 million grant to fund the research programme. And so this is very much based on our strategy, which is linked to the Pears building, which is the Institute of Immunity and Transplantation. So we have, very generously funded by the Royal Free Charity, amongst others, we now have 3 specific consultants who are engaged in early phase clinical trials. So those getting those new drugs out of the lab and into the clinic. And that's going to start with our rare cancers, for example, liver cancer and kidney cancers, but they will also therefore be expanding the programme, which will reach out to all of our patients. Because I think we acknowledge that we in oncology, all of us do clinical studies, but in order to really progress our clinical trial portfolio, we also need to be focusing on our links with the lab, so that we can really bring bench to bedside research across the trust. Thank you very much. I am going to try very hard to stop sharing my screen and see if I can hand over to Kathy.
Perfect. Thank you. Thanks, Judy. And thank you, everybody. Thank you to those who invited me to speak tonight. My name is Kathy. As I said, I'm the lead nurse for breast oncology, and I am the metastatic breast cancer specialist nurse. And I'm just going to talk a little bit today about the support that we offer to our patients and also to their families and loved ones. So really, when we're looking at what high quality care is, there's different aspects of that, and we're all very aware that in order to provide sort of high quality or world-class care, which is the Royal Free vision, we're talking about treatments that work. As Judy has just mentioned, we're talking about how effective our treatment is and also how safe it is. So is it safe? Are the drugs themselves safe? Are we picking the right people for the different drugs? Are people good? Are people going to be able to manage with whatever we're offering? But also a really huge part of high quality care is the patient's own experience. And that's really about their care, their treatment and support. And when someone's diagnosed with breast cancer, there's a lot of new information, you know, what type of cancer it is, what grade and size and treatment, and the whole team really are involved in looking at that and answering those questions for our patients. But really, it is also very important to us that we recognise that our patients are not just patients. They are people with lives outside of our clinics. And we need to make sure that we know how their breast cancer diagnosis and their treatment is going to affect them as a person. How does it affect them? The roles that they have in life, you know, as a woman, as someone who works, as a partner or a friend, as a parent, you know, how are we going to support them? And that's a big part of what we do in the clinical nurse team. Next slide. So really, when we talk about the support available for patients, I'd like to think that a big part of that is the clinical nurse specialists. Our roles really are quite complex, so we've got various different aspects to it, but the bit that's relevant for this is really about the supportive role. So it's about counselling our patients, talking to them about lifestyle modifications, as Claire's already talked about, educating and improving and promoting self-management, and also providing sort of psycho, spiritual and social support to the patient and to their family. And a large part of what we do is referring on to other people. Thanks. One of the services that we refer on to is the Prepare service. So it's a pre-treatment event that happens every 2 weeks. So once a month it's held in Chase Farm, and once a month it's held here in the Royal Free site. And it's a 2-hour interactive session to help people prepare for their anti-cancer treatment, so for their chemotherapy, immunotherapy, whatever else they're having. It's not specific to breast cancer, it's all tumour types, and it's run by the personalised care lead, Asmina, and lead cancer nurse, Gemma. And really, it's just looking at these things down on the left-hand side, so or your right-hand side, talking about personalised care, physical activity, diet, and again, helping with signposting to other services, including the finance team. Okay. When we're talking to our patients about what support they need, it's not the same for everyone. So really what we need to do is we need to have a conversation with our patients and ask them what support they as an individual need. And one of the best ways for us to do this is with a holistic needs assessment, because this is essentially what matters to you conversation. And it can happen at any point in the cancer pathway, but we are encouraged to do one at the time of diagnosis, and another one when somebody has completed their main anti-cancer treatment. And then for me, as the metastatic, it's about when people are newly diagnosed with a metastatic breast cancer. So that's a cancer that we can't cure. And the assessment really, as I said, it's just about starting this conversation and getting a personalised plan in place for our patients and helping to signpost to the relevant services out there. Thanks. And yeah, just so when we are looking at what else is out there within the hospital, we can't offer everything. Every patient has different needs. There's such a wide variety, and we aren't able to provide everything ourselves in-house. But this is where these amazing voluntary services and charities help so much with what we can do and what we can offer our patients. So there are often places that patients can attend without a referral, so people can just pop into a lot of these, introduce themselves. Sometimes we do need to do a referral if they want a specific treatment. But the different support services all offer something different. It can be the type of patient, their postcode, their ethnicity, various different things. So, for example, High Cancer Care supports the Jewish population. Future Dreams supports and runs a Southeast Asian support group and Black Women Rising. There's also support for older people through things like Silverline, Age UK. For parents, we've got Fruit Fly. There's even something for pets where we've got the Cinnamon Trust if somebody has to come into hospital and they need someone to look after their pet. So there's a whole range of services out there, and most of these offer both in-person and online workshops for things like exercise, fatigue management, body image. One we always recommend is the Look Good, Feel Better, because patients go away with a big bag of goodies from that one. But there's too much to sort of go through every one of these, but I've just picked a few of them out, which I'll highlight. So we'll talk first about the Breast Cancer Now charity, because this is the one that we use probably most often within our team, because they provide pretty much all of our patient information that we give out. So it's a really excellent website. They also have a telephone services for nurses, where nurses staff the telephone helpline. So patients can phone up, not about their own specific needs if it's something as a side effect with treatment, but they can talk through an overall plan, or if there's a question and they want a second opinion, or sorry, that's not clear. If they want to talk through their information again, just to help them understand it. One of the services that they do offer is something called Here For You, which is a personalized referral for people with breast cancer, so that someone from this the charity will contact patients, and they talk about they sort of help to manage the impact of diagnosis at every stage, and that's dealing with the emotional shock, moving forward after treatment has finished, or coping with the ongoing challenges of secondary breast cancer. And the Royal Free is always one of the top referrers into that service. We also all know Macmillan Cancer Support. Again, they work really hard at helping to manage the impact of cancer diagnosis, and they offer a wide range of services. Probably two that we link in most frequently is their benefits and finance service, and also counselling. They offer free counselling, which they pay for, and it's via Bupa. Okay. And we cannot talk about support for breast cancer patients without looking at our gorgeous new Maggie Centre, which just opened earlier this year. And it's a beautiful space for people with cancer or for their family and friends. People can pop in, sit in some quiet and just have a bit of peace away from a clinic, or they can go in and talk to someone and get a bit more information and support. So the staff are on hand to help with any advice or signposting that the patients may need. So they do things like nutrition, family and friends support, and they also have a psychologist, which unfortunately was something we've been lacking quite a long time. So we're very glad that that post is back in place. So we talk about support, and we're talking about things that we can do, and Claire's talked a little bit about the importance of physical activity to prevent breast cancer. We also know that it can help people cope with the side effects of treatment and feel well while they're on treatment. So there's so many benefits for their overall health to their heart, their emotional and psychological well-being, strengthening muscles, bone health, which is really important for our breast cancer patients, and improving balance. So we do encourage our patients to be physically active. And we are actually in the process of sort of questioning and getting the views of our patients with secondary breast cancer to see how else we can support people with getting them more active during their treatment. So often when our patients have finished their treatment, they always think, yay, you know, great, what life can get back to normal, but that doesn't always happen. Often when people have completed their treatment, it can mean leaving behind that routine and support that they've become used to by attending the hospital. And sometimes people feel a bit alone at that point. And they're still coping with the shock of the diagnosis, maybe still coping with some of the side effects and then the worries about recurrence and trying to get back to normal life. And we are getting better now at supporting people at this time. Patients are again offered that holistic needs assessment I mentioned previously, and an end of treatment appointment with a specialist nurse, and a health and well-being event to help people moving forward. And then as I work as the secondary breast cancer nurse, I also wanted to talk about that group of patients, because when someone has breast cancer, it can be a really big shock to them and to their families. You know, we've heard from Judy about some of the improvements in the treatment for breast cancer. But at present, secondary breast cancer can be treated but not cured. We're always aiming to control it, to relieve the symptoms and maintain a good health and well-being. But really, these patients can often have a different set of needs to people in the early breast cancer setting. So, you know, support for this patient is be sort of part of that again is my role, but again, linking in with the other support groups. So Breast Cancer Now do have a living with secondary breast cancer. And then we also very much work with our palliative care teams, both in the hospital and in the community. And just my final slide, the title of this was obviously about supporting our patients, but also supporting their families. So when we're looking at the people who are affected by the cancer, it's not just those with cancer, but those who love and support them. So we know that partners often have a really sort of they have their own emotions that they have to deal with, and have quite a lot of questions that they want to ask about or need answered, and we would help them with that. So there's a lot of written literature that we give them, both for partners or as parents. We can give different information, and we also help to signpost again them to other cancer charities. We also, by raising issues that sometimes people find difficult, find some difficulty in talking about, if we bring them up, it makes it easier for them. So we would talk about things like sex and intimacy and how those things can change. And again, yes, talk about the services that are available. We are aware that many of our patients have young children, and we would talk to the families about telling their children and how much or when they want to say. And we know that deciding when and how to tell children about breast cancer can be really difficult. However, even if they don't understand, the evidence suggests they're often much less anxious and less frightened when they do know what's going on. So we try to help support them with stories, signposting to their schools and other cancer charities. All right, thank you.
Lovely. Kathy, just stay on and tell me if you can hear me.
Yes, I can.
Very exciting news. Got there in the end. All right, so we've got a little bit of time for Q&A. I'm going to start. We've had a couple of, Claire, we've had some questions in advance about breast screening, and do we know, firstly, what screening is available for men? And then also, why does screening end when it does? And do we know why that is? And what if people want additional screening?
Sorry, could you just say the first one again, Judy, please?
Screening for men who have high-risk family histories.
So that's through the GP. We'll refer into their local symptomatic unit. With the National Breast Screening Programme, we don't screen men, only those registered female. So anyone who is a male who has got a family history or is high risk, it's a referral in through their symptomatic unit, or directly to the family history to be referred to genetics if they need further testing. And you had another
and the second question
Judy?
was about sort of the upper age of screening. Why are the age limits set where they are? Is there anything, if people are concerned, they can do about that?
So the reason we screen between the ages of 50 and 70, 80% of our cancers are diagnosed within the UK within that age demographic. So that's why our National Breast Screening Programme is targeted specifically with that age group. Anyone over the age of 70 won't get an automatic invite, but they are encouraged to please self-refer every 3 years up until the end of life. And that's really important, as well as being breast aware.
And then the last question was, how do people get involved in the screening studies you talked about?
So the screening studies are usually when you've been invited for screening. Some of them are randomized trials. So it depends on when you've been invited for screening. If you're part of the randomized trials in relation to prospect braid, we're no longer recruiting to. And obviously the small trial that I spoke about and the Laura which has now closed, they had specific criteria. So if you met those specific criteria, you were approached and you were eligible to be randomized for those trials. But anyone who is screened, they can always ask for information when they attend for their screening appointment or contact the hub directly, and I'll happily feed back to them. Thank you.
Lovely. Thank you, Claire. Kathy, can I turn to you? There's a question about food, and particularly, is there any risk related with either the developing breast cancer or for patients on treatment, what they should do?
As a rule, our advice is always about eating a good, well-balanced diet. So before somebody has a diagnosis of breast cancer, it is about general overall health. So, making sure that your food is heart healthy and keeping your weight under control. During treatment, it's the same sort of thing. There's nothing that we would advise people to cut out. There's a lot of low quality research out there about myths about things that people should be cutting out, and we signpost people away from that, and we generally talk about having a good balanced diet.
So no cutting out sugar completely or going alkaline or avoiding
none mushrooms. Of that. No, just a good well-balanced diet. If you fancy the odd slice of cake, it's fine. Don't eat the whole cake. If you fancy a glass of wine, that's okay. Don't have a bottle, These
are probably words to live by, Kathy. And there is a question which is a little bit broad, sort of asking about what are the side effects of treatment. I don't think we've got time for, but I think what might be useful is if you have a relative who's under treatment, you're not sure whether it's a side effect of treatment or something you should be worried about. As a relative, what do you think would be sensible advice?
I think speaking to the person who is experiencing the side effects and see what they know or what they've been told. And if you have got concerns, anybody on active treatment will have been given a contact number both for their clinical nurse specialist, who you can speak to if it's just general information. But if they're feeling unwell and it's a side effect that you're worried about, the patients are all given a 24-hour helpline number, and that is where we signpost people to if they've got a more immediate concern.
And then there were just a couple of questions at the end about risks of cancer. So asking about the risk of the pill. There's a very slightly increased risk when you're on the pill, but it is low and it stops when you come off the pill. Equally, people have asked about HRT. There's two types of HRT. One is for women who've had a hysterectomy where it's estrogen only and there isn't an increased risk. The other one is a combined estrogen and progesterone, where there is a slightly increased risk, but it is not a high risk. The risk is actually much higher from being obese or drinking excess alcohol. So those lifestyle factors are sort of more important. So there is a slight risk with many things, but it's when You have to look at all the other risk factors. And then someone else has asked lastly about the types of different breast cancer. So the majority of breast cancers are what we call ER positive, so endocrine receptor, so driven by hormones. But then there are rarer subtypes which we deal with in the oncology clinics, for example, the HER2 or the triple negatives. But there are those are the three main subtypes as a rule. There's lots of useful information.
Sorry, Judy. I was just going to say, if anybody wanted information or to find out breast cancer now again, they've got information just about signs and symptoms or what to expect, and lots of good information if somebody was worried.
Perfect. Perfect note to end on. So I'm going to hand over to Jane for some closing remarks. Goodness, Jane, I think you're muted now. We're having a night of it. Sorry.
Can you hear me now? Okay, sorry about that. Yes, so first of all, thank you very much to our speakers for their informative, interesting, and very important presentations tonight. Really important stuff. And then finally, just to thank all of you, our members, for joining us tonight, and hope to see you soon. Please see that you can ask any questions that weren't asked tonight, or if you think of anything, please do email us at that email address. And I think that's all I need to say. And thanks to everyone, and we'll see you soon. Goodbye.
Good night.
Thanks. Goodbye.